tests, I'm not going to go through these in details. We can do lots of things if we're suspecting renal issues going on. When you are giving someone contrast, it's super important that you know what their kidney function is. Because contrast is hard for the kidneys to process and get rid of. So if we suspect that you have renal issues to begin with, or you're at risk, or even if you're not, we almost always do renal function tests before we send you in for that cardiac cath or for that angiogram that's going to run dye through your system. We want to make sure that your kidneys can get rid of the dye afterwards. You know, we're not going to stress your kidneys out too much. We also will do a good med profile. These meds that are listed here are pretty nephrotoxic. So you have a 70-year-old you want to do a contrast procedure with, and that 70-year-old, that's a risk factor, first of all, and she says, well, I take an NSAID every 4 hours for my arthritis. Well, that's another risk factor. Let's do some really good renal function tests to make sure that we're not going to stress your kidneys out as a result of this procedure. And if we are, maybe we need to consider, is there a different diagnostic test we can do? Because otherwise, you may send that patient into acute kidney injury following the procedure because the kidneys now are also stressed out because they're trying to get rid of your contrast. In red and bold are the things, definite criteria that we use. So given a patient profile, given lab results, and you see that that serum creatinine level is above 1.5, really call and give consideration whether that contrast procedure is necessary or not. Pay attention to stuff in red more so than the little bitty detail stuff, not little bitty detail stuff. But if you're asked this in a couple of weeks, this will be the number to watch out for. So your patient is scheduled for a cardiac cath tomorrow. This is the patient's profile. What risk factors does she have, or which one of these findings warrants contacting the healthcare provider? If you see that elevated serum creatinine number, that's the answer. Also important to know, if your patient takes glucophage, which is metformin, we tell them to hold that metformin before the procedure for at least 24 hours. Afterwards, I don't want you taking your metformin for at least 48 hours, and I don't want you resuming that until we've checked your kidney function tests. That's the patient teaching that will need to go with that. For any contrast procedure. Yes. 24 before, at least 48 hours afterwards. You're sending your patient home after following your renal angiogram, and you see that she takes metformin. What patient teaching will go with that? Well, you need to not resume your metformin for at least 48 hours. Today is Wednesday, so at least need to hold on, not take it until Friday. And I want you coming in on Friday afternoon, and I want to run some renal function tests, and then if they're good, then you can resume it on Saturday. Or Friday, or whatever, however that works out. But that's how that conversation teaching could go. Again, in red and bold, the last several slides, check kidney function for at-risk patients. We can do endoscopies. We've talked about scopes and other avenues. Kidney biopsy, if you're doing that, they're very vascular. The normal concerns you have for post-procedural bleeding, which we've been talking about all along. Check your hemoglobin, check for dizziness. I know it hurts, but I'm going to have to look at your backside. Don't rely on what's on the bed sheet. If they've got bleeding or something else going on externally, I need to really look underneath you and make sure there's nothing going on. Post-biopsy, their urine may contain blood for a period of time, just because it's been traumatized, but it should clear in the next day or so. Yes, because yes, I under the abdomen, because if I'm having you recover from your post-op, I'll probably have you in the prone position, and then we put a sandbag on the abdomen to keep that kidney elevated. That's the thinking there. Good question. Okay, we're going to take a break. What questions do you think are most, or what content is most important to what we've covered within the PowerPoint?
Lab values.
Absolutely, the lab values. And they always go the same direction when we have renal patients. So unlike cardiac, where sometimes it's up, sometimes it's down, that's not the case here. So without looking at your notes, which way will the serum creatinine level go? Which way will the creatinine clearance go? Correct, and that's directly correlation, right? It keeps getting produced, can't get cleared. Which way will the GFR go? Down. How about the hemoglobin? Down, because what gets produced by the kidneys? Erythropoietin, and that's responsible for your red blood cells. And if you have decreased erythropoietin production because you don't have your kidneys working correctly, therefore your hemoglobin and your red blood cells will go down. What about blood pressure? Up, because the whole renin system is messed up correctly. Serum creatinine, BUN, up. Serum creatinine, we cover that, yep. GFR, we'll cover that. So, which way will your specific gravity go if your patient's dehydrated? Up. Correct. So all of those are important to know, to understand physiologically why they're changing the way, the direction they're going. There will be questions throughout your patient care that you're going to want to keep an eye on that whole renal system. What are the kidneys doing? So therefore, those labs should be really easy for you to figure out for sure which direction goes what, and that you're monitoring all of those. Contrast procedural, teaching, monitoring your patient, all of that. Check kidney functions before, after. Could you identify risk factors given that? Patient teaching about metformin after contrast procedure, absolutely. Kidneys are vascular, post-procedural. If you got some kidney invasive procedure you're doing, what you're monitoring for post-procedurally. Anybody else have another thought or questions about what we've covered?
I kind of flew over that urologic endoscopy. We don't need that.
No. You've been knowing about the scopes all along, so. Any other questions about that? Okay, I've got 12 after on this clock. You want to take a break until about 22 after. Also, I have handouts for hematology next week, because I know it feels like probably a lot, like there's like bazillion anemias. If you want a handout today, I'll lay it up here. If you want to wait and grab it next week, that's fine too. But some students said, gosh, I wish I'd had this ahead of time. I could have made some notes on it. It's up to you.